Okay, so welcome everybody. My name is Christine Kai and I'm with the Quartet Division of Family Practice. And I am presenting from the traditional and treaty lands of the Klahaman people, which is just 2 ferries up from Powell River, from Vancouver, and used to be called Powell River Division of Family Practice. And I'm very pleased that you guys are joining me on this webinar to explore other models of primary care. And with me, we have STEPS and we have Shoreline Medical. And I've asked them to talk about their organization. And before we do so, I hope you guys can introduce yourself, and then you can decide who wants to start first. Okay, Christine, you want to start as introducing yourself?
Yeah, sure. I'm Christine Matuschewski and I'm STEPS CEO, and I've been with the not-for-profit since 2018. So it's been a few years, and we've grown from no patients to operationalizing our first clinic. And now we have 5 clinics and we serve about 17,000 people. So we continue to grow and yeah, it's very exciting. So that's me. Maybe I'll pass it over to Dr. Smillie.
Hi, I'm Tracey Smillie. I'm a family physician with STEPS. So I've been with STEPS for almost 3 years, I think, just before the pandemic. And I'm at the original clinic that STEPS opened called Orchards Walk Clinic. And I've been a family physician for about 20 years, and I've had an opportunity to work in all sorts of different kind of practice styles and locations. And this is by far my favorite so far.
Great. Karen, you want to go next?
I'm Karen Morgan. I'm the interim executive director of Shoreline Medical Society. And I've been with Shoreline for just over a year, but I was involved in the formation of Shoreline. So I've been around this idea of a nonprofit primary healthcare center since about 2004. Previously, I was with the Saanich Peninsula Hospital and Healthcare Foundation. And I'll pass it over to Chris Dowler now.
Hi, everyone. My name is Chris Dowler. I'm a family physician at the Sydney location, or Sydney clinic of Shoreline Medical, the original site. I'm also now the medical director, and I've been the medical director now for about a year and a half. And I've had a family practice here since the very beginning. When Shoreline was founded in 2016 or so. And it's a pleasure to be here. Thanks very much for having me.
Great, wonderful. Who wants to start with a little overview? You already give us a little bit of an overview, but we sent also some questions to you. Who wants to start?
I'm easy. We're happy to start, or whatever you guys are comfortable with.
Whatever works for everyone else. We can flip a coin.
Okay, Christine, you go for it.
Okay. So yeah, I'll just start by giving a little bit of a history for 4 steps and our journey so far. So in 2012, the GP for me was initiated by the government at the time. And it was all about attaching patients, and a GP for me for everybody. And the Thompson Region Division of Family Physicians, the membership, identified seven projects and 7 focus areas for the work that they had proposed in regards to attachment. One of those was an incubator model. And through that work came a multi-physician team-based care business plan. And in 2016, that was finalized. And the physician lead at that time, Dr. Selena Laurie, realized that if she didn't do something, it would probably go sit on a shelf. And so she took that, and she found a group of really passionate community members with special skill sets in business and law, accounting, and other critical skill sets to come together and form supporting team excellence with Patient Society, or STEPS. And that happened in April of 2017. Through that summer, there was an IMG process in our region, and we had 3 IMG spots for the Kamloops region, and those 3 IMGs who matched to Kamloops really wanted to work together. And so they helped us operationalize Orchards Walk Medical Clinic in May of 2018. And we did a lot of learning, and there was a lot of definitely hard work that, really none of us had anticipated how difficult it would be to start a community health center and really start a primary care clinic. So we did that. We started off on a base rate of pay. We soon learned a lot about physician compensation, and we changed things to the fee-for-service model and doing a 70-30 split. And since that time, Orchards Walk has flourished, and we got to the point where we had people, too many people for the space, and then we also had other physicians and clinics in town interested in joining our model. We also, through the pandemic, received some grant funding, and we were able to hire other allied health professionals like a social worker, registered nurses, clinical counselors, occupational therapy, pharmacists, and some other really great people to help us on our journey and our work. Today we have a number of different clinics, and we have an interdisciplinary team. And what it keeps coming back to is the people within our organization that make the difference. And so we have a strategic plan, we have a vision, we have a mission, and we have values. And those team values and those clinic values and the way people come together is really critical to delivering integrated, collaborative, team-based healthcare. So we are continuing to do this work, and that's our journey to date. And we do see over the next few years that that there's the possibility to grow. There's obviously challenges with the community health center model, in the funding system in BC isn't set up to really provide global funding packages or community health center packages in the way that meet all the needs, including social determinants of health. The BC Association of Community Health Centers, or BCACH, is a really great organization that is doing a lot of provincial work, and we as in STEPS are members of BCACH and the Canadian Association of Community Health Centers in our pursuit for federal and provincial funding models that really meet the needs of thriving community-run organizations like STEPS. So that, in a nutshell, is STEPS. Tracey, do you have anything to add? Did I miss anything?
Christina, I always think you do such a great job of really summarizing where we're at with STEPS and where we started. And just as a physician, I can speak to my experience, and Christine's probably best to speak to the overall structure. But my experience has been great. I've really enjoyed it. Like I said, I've come from all sorts of different practice backgrounds, and this one has been the most rewarding for me in terms of being able to practice family medicine in a really safe collegial environment where you don't have to think a lot about administrative duties and day-to-day function of the clinic. And so I've been really happy with it. And I would like to agree with Christine. I think the biggest thing for us going forward is just making sure that we can continue to sustain the model, that we have the funding to do so, and that we have the people that continue to be of like mind, so that we can kind of work together towards the same goals.
Great. I already have lots of questions to ask you, but maybe let's hold on with those questions, and let's first hear from Karen and from Christopher. I think that's my cue to start the presentation.
Can you start the presentation, please? Thank you. Second slide, please. So the Shoreline Medical Society really grew out of needing to deal with pending physician shortages at the Saanich Peninsula Hospital. we started to notice retirements of older physicians and their inability to recruit replacements in the early 2000s. And the Saanich Peninsula Hospital Foundation began researching ideas from other parts of Canada. And in about 2012, we received a grant from the South Island Division of Family Practice. And along with that grant came a researcher who helped us move things forward. By 2015, Shoreline was founded as a nonprofit society. And shortly after it achieved nonprofit society status, we applied for registered charitable status shortly after in order to be able to accept donations. And this was originally intended as a way for us to accept donations from the Saanich Peninsula Hospital Foundation, which had recognized that it was important to support the recruitment of physicians in the community if we wanted to have physicians working at the hospital, because Sanpan Hospital, in spite of it being close to Victoria, runs on a rural model. And so the community physicians provide the services at the hospital. Now, Shoreline's board was comprised of community members and physicians. And from the beginning, physician input was regarded as critical to building the right model. Our first site in Sydney opened in 2016. Christian, could I have the second slide, please? Since opening, operating funding challenges have been frequent and regular. The town of Sydney stepped in during our first year to provide a bridge loan of $190,000 while the process of charitable status achievement continued. And we received charitable status in early 2017. And by then the foundation, which had changed its name to the Saanich Peninsula Hospital and Healthcare Foundation, began providing capital funding. And to date, they've provided approximately $4 million in capital funding and about $1 million in operating funding. Shoreline has grown from 4 physicians at one site to 25 physicians at 2 sites. So we have a larger site in Sydney and also one in Brentwood Bay. Shoreline physicians pay an overhead rate that's equivalent to market between 28 and 35%, depending on their FTE. And Shoreline physicians provide more than 60% of the service at the Saanich Peninsula Hospital. So we've really felt that this has succeeded in assisting in solving this problem. We thought when Shoreline opened in 2016 that it would solve the entire problem, because at that point there were 10,000 people on the Saanich Peninsula without a family doctor. And at the end of 5 years, we looked again at the numbers, and there were still 10,000 people without a family doctor because of ongoing retirements in the community. So our work continues. Next slide, please. Okay, from the governance point of view, it was very important, as this is a society, a charity, and an organization that was driven by the combination of community members and physicians, that the board of directors should be comprised of both community members and community longitudinal family physicians. We have both retired and active physicians on the board right now. Next slide. Chris, would you like to take over now, please?
Yeah, sounds good. Thanks very much, Karen. And once again, it's a pleasure being here today. Thanks very much for the invitation. So I'll speak a bit about the operations of our nonprofit medical society, and talk about sort of the pros and cons that we've experienced. So firstly, the governance is arguably the most important, or one of the most, so there's probably a few very important points here. One is the charitable status, which Karen touched on. Two is intentionally setting up the governance so that physicians working on the ground have a direct say in how the society is governed, and with critical decisions that are being made that ultimately affect operations and affect patient care, because nobody knows this business better than physicians, frankly. I know there's lots of other people coming into the fold now to community care, but for generations it has primarily been primary care physicians doing this work. So having physicians at the governance level is very important. Moving on to operations, we've been very deliberate in how we've come together. Oh, sorry. Last slide. There we go. We've been very deliberate in setting up a culture, incorporating a number of principles that we feel are very important, and all of our physicians feel is all very important. So a culture of collaboration, of support and mentorship. So we have physicians throughout the spectrum of their careers mentoring each other. And that has been huge in getting young physicians being willing to sign on and take over a practice, and the huge responsibility that is. We have a culture of efficiency. So we just try to get things done. We try not to get bogged down by too many meetings, too many people being involved, but all the while still getting our physicians engaged in all major decisions or significant decisions. And that allows them to preserve the autonomy within their own practice. And so Shoreline is simply here to support them in running their own autonomous practice, essentially. And we try to operate very transparently with our physicians. That includes showing them books. With the private practice model, we have a clinic owner and associate physicians, and there's not a lot of transparency in the finances. And I think that's very important to getting physicians engaged and feeling as though they're part of something, even though they don't have ownership. So next slide, please. So we have a well-established operational structure that is fairly lean, and that's important. So we have good people in the right spots. We have an executive director, and that's Karen. She's on the call here, and she's more externally focused, liaising with community organizations and donors, contracts, that kind of thing. We have our operations director who oversees the operations of both of our clinics and makes sure that there's consistency there for all of our staff, and our staff are interchangeable between both clinics. And physicians can work at both clinics and see the same sort of processes. So that leads to efficiencies as well. We have an HR manager who hires and helps fire potentially our numerous staff. And during COVID, that has been a profoundly challenging job. In the year of 2021, I understand that we had 20 staff members quit, and we hired 20 staff members during a pandemic. It was profoundly challenging, and when you throw in all the training that's involved with that, so our HR manager is worth her weight in gold. We have a chief financial officer who helps oversee the financial operations of the clinic. He's a magician with money and helps us in ways we couldn't even imagine. We have a billing specialist who is just extremely knowledgeable with MSP and WorkSafe and all different forms of revenue that gets generated through primary care, and helps our clinicians maximize their revenue within the confines of our publicly funded system. We have multiple levels of management within our MOAs and graduating levels of responsibility. And then we have a couple of medical directors, one for each site. And one key point is that both medical directors, myself and Dr. Sienna Bourdon, who some of you may have met in the past or in other sort of settings, both of us have family practices. And so our boots are on the ground. We talk to patients every single day, just as much as anyone else. We hear what the issues are in the community, and we can support our physicians that way. Contrast that to other endeavors where other group family practices are coming together. The medical directors are often just put on salary and don't have practices. And that creates for some uninformed decision making that has its consequences. So all in all, we have 24 family practices and a staff of collectively 35 to 45 people employed by us. Next slide, please. Thanks. So we've really tried to roll out team-based care as best we can. Again, within the confines of the PCN, we don't receive any block funding to hire our own staff, which we would certainly prefer. So we have full-time longitudinal doctors. We have part-time longitudinal doctors. We have doctors mostly working in fee-for-service, and we have a bunch of new-to-practice doctors who are on the contracts. And we've somehow found a way to have everyone working fairly harmoniously under one roof, which has been a significant challenge. And when I say our financial officer is a magician, it's because he is, because it is difficult to get full-timers working together with part-timers, and to get fee-for-service doctors working together with new-to-practice doctors, and have everyone work harmoniously. That is quite a challenge, and make sure that nobody feels like they're hard done by or being taken advantage of. We have lots of locums. We have a walk-in clinic attached to both of our longitudinal clinics, which but they're extremely busy. I think we were funded through the walk-in clinic stabilization funding for 2.5 FTEs. So we are by far and away the busiest unattached patient care center as well in Southern Vancouver Island. And supporting us, we have a number of PCN resources. Nurses, social workers, mental health counselors, and social work, substance use counselors, and we now have we have two clinical pharmacists as well, and we have a private paid LPN that helps support us as well with various procedures. So caring for patients and compensation. So there was a number of questions that were asked of us in advance of this presentation, and so I think we did our best to summarize things here with respect to compensation. So patients are attached to an individual physician. And so we have autonomous practices with working under the umbrella of Shoreline. And Shoreline simply provides all the administrative support and workflows and stuff that allows people to work together as a team. And then we cross cover each other both in terms of access in clinic, telehealth, and in person. We also support each other by cross covering our community call overnight and over the weekends, and we also cross cover each other with our attached patients at Saanich Peninsula Hospital, which we all take turns working in. Sorry, just 1 second. There's a screaming child outside the window here. Okay, moving on. Yes, so I already touched on the cross cover at San Pen, and that's been a very significant challenge because at any point in time, we have at least one, usually two doctors out of the office working in the hospital, caring for attached and unattached patients. And that creates a vacuum in our clinic, which necessitates the need for a lot of locums and cross coverage amongst our colleagues. So we truly have we have no choice but to have a team-based care model because of our commitment to the hospital. Our pay structure is proportional to complexity and volume as would be in fee-for-service. Not that fee-for-service accurately compensates for all forms of complexity, but it's there. Anyways, we get paid the same amount as anybody else working fee-for-service. But we do have a billing specialist who helps us maximize those billings within the confines of our system. A key component is we do not charge overhead on work done outside of the office. And so that puts a lot of pressure on our managers to make sure that locums are recruited and absences are filled. Um, yeah, and we generally see 25 to 30 patients a day for a full day. So here's some, I suppose, some insights. With regards to team-based care, we had to come up with an overhead model that worked for, as I mentioned earlier, for all shapes and sizes of practices and funding sources for practice, all of our different practices, and preventing erosion amongst physicians is quite challenging, and you have to sort of toe the line and come up with a model and stick to it. We've found that to be quite challenging. So I'm hopeful that in the coming weeks, there'll be a billing model that will be palatable and appealing for all doctors. And it'll be scalable based on practice size and complexity and all that, all those nice things. But yeah, having an overhead model that works for everyone is a challenge. And if anybody wants me to go into more specifics on that, I'd be happy to, maybe in the question section or question period. Training of allied healthcare providers and training of the numerous doctors that are continuously coming in and locuming for us or joining us and starting practices has been a huge task. And so we've become quite efficient at training people now, and that's a huge part of it. And unfortunately, with the PCN, training is quite lacking with allied healthcare professionals. So we've had to take it on ourselves to do that. We've developed internal referrals because we have lots of doctors who do different things. And so we try to support each other and try to take care of our patients internally before we have to refer externally. We don't have any specialists. Oh no, sorry, we do have one specialist. We have a physiatrist, but anyways, we have mostly GPs working within us or within our clinics. Utilizing our space has become very important, but particularly with telehealth. And so we choose to have physicians work either telehealth half day or an in-person half day. And that allows us to staff our clinics accordingly and have patients seen in a timely way. When you start working as a team, there are some things that change as well. Documentation was initially quite a challenge because we had some old time physicians who liked to get their notes done within a week or two and liked to document things perhaps not quite to the standard that other doctors would need to accurately sort of understand what was going on in that interaction. And so trying to get physicians on board with a basic standard of quality of documentation and timeline, so like when the notes need to be done, is very important. So my patients, I know that they're going to be seeing the nurse, a social worker, etc., and those providers need to be able to read my most recent notes in order to actually be able to help that patient. So I need to get my notes done very quickly. Well, try to get physicians to change their behavior is very, very challenging. And trying to do that in a respectful way is extremely challenging. So it's taken us about a year to a year and a half to finally get to this point where our physicians are getting their notes done same day, and patients can come in the next day and have seamless care. So that's a challenge with team-based care that we weren't prepared for initially. More specifically on the nonprofit model for primary care. So of course it has lots of advantages, and I would encourage it for every community around the province, hands down. We have created a wraparound sort of longitudinal care organization. So patients get us, whether they're in the community or in the hospital. Lots of familiar faces and ultimately better outcomes, we believe. Our community, and here's possibly the most important point with respect to the primary nonprofit model, is that our communities are empowered to improve their own primary care. And that is certainly something that is lacking in most communities around BC, but on the Sandwich Peninsula, our patients can donate to the society, which then builds these new clinics that recruits doctors that ultimately help improve their own healthcare. So it's unlocked the potential of our communities. Of course, we have supportive environment for providers, which sounds like what STEPS is also doing as well. And ultimately, this has all resulted in a very significant improvement in recruitment and retention of our physicians. And the attachment of, I believe it's somewhere around 12,000 patients within the last 6 years, and overall improved community health. There are some challenges with the nonprofit model. Firstly, when you open, the community is going to have very high expectations of you, and they will overwhelm you. And so be prepared for that. Obtaining charitable status with the CRA can be tricky, but it's not impossible. I'm sure Karen could answer more questions about that as she was more directly involved in that side of things. But not just obtaining it, but maintaining CRA status is also challenging as well, because there are some parameters that the CRA has, or requirements that the CRA has, that can sometimes make it challenging to run a clinic. Of course, once you're a nonprofit, then you have to fundraise, and that's a whole other arm of the organization. And when you have donors, then donors often have expectations, such as cash for attachment. So if I donate, do I get a doctor? Or if I already have a doctor and I donate, oh, doctor, can I please have that expedited MRI? Or can I please have that, special test that I don't really need, but I want, right? So managing those expectations has proven to be challenging. And so we've actually blinded all of our doctors to who has donated and who hasn't. And who has donated is a well-kept secret from our doctors. And we ask our donors not to let our doctors know if they've donated or not, because we want to preserve that physician-patient relationship and not have any sort of extraneous factors involved in decision-making. Of course, other clinics in the community will be impacted by this, because you will be able to recruit very well, provided things go well, and that will have an impact on other clinics in the area, and it could potentially be destabilizing to the private practices in the area. We have seen that, and there are some private practices and other doctors in the community who are a little resentful of us. But meanwhile, we are addressing the community's needs, and so engagement with community partners is very, very important in this process. And it also a challenge with this model is that physicians still need to pay overhead, which is a requirement of the CRA. And with the current billing model, that is a bit of a handcuff, although things are changing soon. So a quick slide on the PCN. We've integrated PCN resources, nurses at both clinics. We actually have a walking clinic nurse now in Sydney, and we're trying to integrate her and get her functioning as autonomously as possible. We've also integrated a social worker, mental health counselor, clinical pharmacist in a hub and spoke model. The hub and spoke model initially was thought to be a great idea, but what the feedback we've gotten from our allied healthcare partners or workers is that they feel isolated and they want to be integrated into our teams, physically located in our clinics. But we can't do that right now because the PCN doesn't provide overhead support for allied health to be in our clinics. And so we've had a huge challenge. We've had a really hard time recruiting allied healthcare professionals to be part of our PCN. And once they join, they often leave fairly quickly because they don't feel supported and they don't feel part of our team. And so things need to change at a high level, at a provincial level, to get PCN allied healthcare resources working side by side with physicians and nurse practitioners, et cetera, on the ground in clinics, if the PCN is going to work, and that's going to require overhead funding. So hopefully that will come down the pike soon enough. I mean, I'm sure it's the same across the province, but it's worth mentioning that our PCN providers actually document in our EMR, and so their notes are mixed in with the physician notes, and there's one continuous clinical document, which is very helpful for continuity. And that's it. Sorry, I think I took a lot of time there.
Thanks, Chris and Karen. And thanks again, Christine and Tracey, for your overview. I made a lot of notes, and I have a lot of questions. And I'm pretty sure that some of the physicians on board on this call, Chris and Brigitte, have some questions as well. So before I go into the lists that the questions I have, and then some additional questions, I want to ask Brigitte and Chris if you already have some questions you would like to ask some of those presenters. Chris, go ahead.
I can go ahead, sure. Yeah, thanks so much for spending some time with us today and sharing your models. It's I almost didn't come and thought I could go for a little walk instead, but I'm really glad to hear how successful you have all been. And so I also have a long list of questions, so I'm not gonna, I think, ask all of them, but there's probably a lot of overlap. Maybe to start, I'm curious, so it sounds like you're both have very successful models. And I'm wondering what part of your model you attribute to that success. Is the nonprofit part of it a big piece? You'd kind of just elaborate a little bit there, Chris, on some of the benefits there. Is it that cultural piece? Obviously, the individual members of your team are really important, but what is it about the model that you think really makes that difference to make it so attractive for recruiting and retention and for a place that people want to work?
I'm happy to tackle this question. So the nonprofit model allows for an influx of capital to build the infrastructure. That's the key point, right? And it also empowers a community. And that's something that hasn't existed elsewhere, to my knowledge, although I'm very pleased to meet another organization that is doing the same thing as us. So that's one side of things, right? Because in order to change to reform primary care, you do need infrastructure. And our funding comes without strings attached. So we can do what we want with it and make meaningful decisions that are going to actually help, right? As opposed to government funding, which often comes with strings attached and all sorts of bureaucracy, right? So another key component is the governance of our society. As Karen mentioned, we have physicians and community members on our board. And our community members have various backgrounds which help contribute to the success of our society. We have a lawyer, we have an accountant, and we actually have a builder on our board that helps. They've been very instrumental in building our society, building our clinics, right? But then we have physicians on the board as well, not just actively practicing physicians who can bring the issues of the day directly to the decision makers of the board. We have retired physicians who understand what primary care has been like in that community and the relationships with various organizations or cultural groups, and all these things that often aren't even written down, right? And they can bring that context to the table. And so I think it's a really nice mixture of community members and physicians, retired and active, that ultimately result in very healthy discussions and good decisions being made for future direction of the society.
Thanks, Chris. Christine? Oh, sorry.
I'll let Tracey go first.
Okay, yeah, go for it, Tracey.
I just want to say how fantastic it is to hear all about Shoreline. It's just lovely to hear about a different group doing something similar. And I've actually jotted down a bunch of things that you're all doing that I want to talk to Christine about later. So that's been really, really helpful. So not just about us telling the other physicians what we're doing, we're learning as well. And I just wanted to say that I absolutely agree with what you said, Chris. It's like it's the not-for-profit structure. But one of the downsides of the not-for-profit structure is that you have to apply for the funding, which Christine has been instrumental in doing for us. And it's with that funding that we've been able to get, all of our allied healthcare providers. And one of the downsides of that is the feeling of, is that funding going to be sustainable? So there's no strings attached to it, but how long will that funding be there for? So that's always been one of the things that as a physician, we've been kind of thinking about, oh, this is so great to have this social worker, this clinical counselor, all this support, but is this something that we can maintain in the long term? And then the other thing, bang on, Chris, what you said about it being the people, the governance structure, which is fantastic because you have the opportunity to choose people and invite people into the organization that are going to contribute. I would say one of the downsides of that, though, is that when you have really, strong leadership within your group, which we do, sometimes it makes us feel a little bit nervous, like, oh, what would happen, if that leader weren't here? Would our organization be able to continue as strong as it continues now? And Christine's like a prime example of that. She's a very, very strong CEO who's really spearheaded a lot of different applications and different projects and different ideas. And we've got a really strong board. And I just want to make sure that we can continue to carry forward with all of our initiatives and that it not be just dependent on one or two really strong leaders.
Great. Anything to add, Christine or Karen, or should we just ask Chris for his next question?
I wanted to add something about our specific nonprofit model. Because we're set up as a charity, we have the option of going to the community for funding. And this is, the Saanich Peninsula is a community that has historically really supported the important causes. In particular, while I was with the Hospital Foundation, we grew the revenues there from about $1 million a year to about $5 million a year. And this is a community of about 60, 70,000. So it's not a huge community. I really feel that as long as Shoreline is demonstrating that it has impact in the community, and it is demonstrating that, funders, local funders, will continue to support it. I understand the challenges of working with provincial funding pools and how fickle politicians can be about providing those. And that's one of the reasons that I felt very strongly about having a model where you could appeal to the community to get support.
I don't have much more to add. We don't have charitable status though, and it's purposeful in that we have organizations that we partner with to achieve the goals that we would want with having charitable status. And we do that purposely because the not-for-profit business model without the charitable status allows us different freedoms. So I think that there is some ways of achieving what you want to achieve in that same engagement of community. And there's tremendous, in-kind expertise, fundraising, space. There's lots of different ways to utilize that community capacity. But I think that business model and how you achieve those goals in looking at all your community resources is a really important piece. And like Shoreline, we have an accountant and a lawyer, a business specialist, an Indigenous person, somebody who's amazing at fundraising and charitable endeavors. And that composition of your board of directors is really critical. And then all of our physicians are ex officio directors. Our medical directors at each of our clinics are invited to our board meetings and regularly attend. But all of our physicians, it's an open invitation to go to our board meetings at any point in time, so that our board is connected with physicians, however the physicians want to connect with the board of directors. It was a good question. Thanks, Chris.
Thanks so much. I'll just keep going along here if that's okay. So I'm curious, when you all started, when you both started, it sounded like, at least for Insanich, there was a big push from the hospital foundation around the requirements there. I'm just curious, this is a lot to get going, a lot of structure and culture and physical infrastructure. And I can only imagine, we have a small clinic that, we put a lot of time and effort into run. Who was really driving that, or who were the people that were really involved early on? Were there a couple key clinicians, a couple of folks from the hospital? Who was actually there driving it? Because I would imagine it would have been just a lot of work initially to really, and ongoing, I'm sure as well, but just to get things going.
Yeah. So for STEPS, it was our board of directors, Dr. Selena Laurie, the IMGs, those 3 IMGs who started. Like, there was a tremendous amount of, getting the clinic up and running. Our board of directors was key, and those special and those key relationships within the community. One of our directors was very involved with the community futures in our area, and we got a $260,000 loan that was unsecured. So that's unheard of almost. And so that was what what kicked off STEPS. And within the year, we'll have that loan paid off. But that was a big deal, and it really was those key connections with our board of directors and that physician knowledge and medical knowledge of being able to start. Our physicians are also really connected with UBC and teach residents and medical students, and so there's a very large piece of that recruits and retains family doctors just in that culture.
And at Shoreline, it really started, as I say, because of physician departures from hospital service. And it was the chief of staff and I, when I was with the hospital foundation, that began exploring what could be done. It took, at that time, it took a very long time to convince people that change was necessary. We, both the chief of staff and I, began talking about this regularly at meetings that we went to. And it just happened that the Collaborative Services Committee of the South Island Division of Family Practice asked me to sit on that committee, and it gave me a forum to continue talking about it. It gave our chief of staff a forum to continue talking about doing something. And that was actually how we got the grant and the researcher. And the researcher from that time is still with Shoreline as our long-term interim chief financial officer, or as Chris calls him, the magician. And so when it was about 2012 when hospital service collapsed. Well, it was on the verge of collapse. There were not enough doctors providing doctor of the day service at the hospital. And the foundation, I managed to convince the board that there was no help coming from the health authority. We had to do something. And we brought in, thanks to a group of donors, incentives for physicians, both new physicians and established physicians, coming back to hospital service. And we were able to bolster the ranks to at least 25 doctors, which was an increase of about 12 from its most critical point. And that was, seeing that success was really important for the foundation board. And that brought the chief of staff and myself together with a small group of doctors in the community who'd been talking about a primary healthcare center for a long time. And things began to move faster at that point.
I'm also curious about that inpatient model a bit, because we have or we're headed for similar challenges maybe here on our inpatient model, and our community is kind of looking at different models for that as well. And so, I don't know, Chris, could you talk a bit about logistically, how do you mentioned a bit about some of that cross coverage. So if I'm in the hospital seeing everyone's patients for a day, 2 days a week, however, what happens to my practice paperwork? How do you logistically manage that, and how, yeah, what are the challenges with that? Because we're struggling with that process.
Right. So, so our physicians are out of the office for a week at a time. Monday to Sunday is the rotation. We do that. Each of us does that 1 week every 2 months, as part of our commitment to support the hospital. Because of course, Shoreline was essentially born out of an idea with support from the hospital foundation. So it's a give and take model, right? But it is a bit of an Achilles heel as far as our clinical operations in the community here. So we aggressively recruit locums. Here's a key point actually. So hospital care now is actually fairly well incentivized. It certainly pays a lot more than community practice does, and certainly pays a lot more than locum in the community does. And so we, as a physician society at the hospital, created a return of service expectation. So if you're a locum and you're awarded a week at the hospital, and we have no problem recruiting doctors to work at the hospital now because it's so well paid, and also a lot of the doctors graduate not wanting to do community practice, but they want to be hospitalists. Certainly in Victoria now, because that's just the culture and the education and the family practice education system here these days. If you want to do a week of Doctor of the Day at San Pen now, you have to do 2 weeks of community care at one of the clinics that supports the hospital. And so the hospital, so it's a bilateral relationship. Yes, we send our doctors to the hospital, but in return, we get locums coming in and backfilling us through that reciprocal relationship there. It's a little controversial. Locums are really frustrated by it. But then the locums that were really vocal against it actually have come to really enjoy their rotation, and you know, their clinical skills are maintained in both arenas, right? So the return of service is very important to the hospital, in our community anyways. It's the only way we can actually get that to work. And we have very efficient, onboarding packages or onboarding processes to get new physicians up and running in our clinics. We have very efficient EMRs. We've done countless quality improvement projects on our EMRs to make them just super simple for new physicians to walk in and use right away. They're very, very intuitive. So that barrier of not understanding the EMR and not knowing sort of how the internal flow of the clinic works, we've tried to minimize that as much as possible. And that is actually, we've gained a reputation locally as being the easiest place to practice at. So if you're coming out of the gate, out of residency, you're probably going to choose us at some point in your first few months, because we'll make your life easy, right? And so optimizing the clinic operations has really helped our recruitment, believe it or not. And of course, education. And it sounds like everybody on this call is involved in medical education in some capacity. And we are very involved with the local residency program, both with offering electives and having primary preceptors at our clinics. So, and all that allows us to recruit fairly effectively, probably compared to the average longitudinal, compared to the average community practice.
So most times you'd have a locum covering you for that 1 week then, by the sound, right? For that.
Sorry, yeah, the punchline is, yeah, we just get a locum to cover us, but
yeah, okay.
getting them to do that,
getting the locums, yeah,
extremely challenging, and the way we do that is what I've just described.
Yeah, carrot and stick. And then, your inpatient model, then that's not a fee-for-service model then, that's a hospitalist model that's funded by VIHA, is that right?
No, actually it is fee-for-service.
Oh,
yeah.
How's it so lucrative then?
It's busy.
Okay.
It's busy, and we have, a few years ago, we figured out how to bill call-ins and stuff like that for new consults and that kind of thing. So
okay.
if you game the fee-for-service system well, it can be lucrative. Also, our hospital was one of 7 hospitals around the province about 5 years ago that received stabilization funding to rescue our inpatient care. So I think we received $500,000 a year for the last number of years to pay our acute care physicians, and we've created a system whereby if you admit a patient, of course you bill fee for service, all the usual codes, but then you get like a top up. And then if you do a discharge, you get a top up, right? So where the most work is, you get a top up essentially, and that has really motivated physicians to work hard, and it works really well.
Great, thanks. Maybe I'll stop there for a bit, Christine, to give you a bit of a chance to say something or to ask some questions.
No worries. I think you were on a roll, but I'm very interested to hear from Christine and Tracey as well, that you guys are also connected to a residency program. Like, do you feel that your model has also increased your ability to attract and retain physicians?
I'll just speak to that, Christine, if that's okay. So yeah, definitely pretty much everyone who works within STEPS is a preceptor for the UBC Family Practice Program in Kamloops. And we have I believe, a fairly high retention of residents that stay in Kamloops. And, you know, obviously the more they train at your clinic, the more they want to come back and do locums or either join. So I think that's been a really successful part of our model. We in Kamloops are quite different than what you're describing, Chris, at Shoreline, because Rural Inland Hospital is, you know, a large tertiary care center where very few family doctors are practicing both community and hospital care right now. So most of the physicians that are working for STEPS are primarily doing community longitudinal care.
Thanks. Another question, and I will hand it back to you, Chris. You mentioned, Tracey, that you've worked in different settings, and I know, Chris, from your bio, I know you've worked in different settings too. And Tracey, you mentioned that this is by far the most satisfying environment you've worked in. And really like to hear, like, as a physician perspective, what makes it so satisfying?
So as a background, I initially, when I graduated, worked for a clinic that was run by another physician. And there wasn't a lot of transparency in terms of finances, and it created a lot of internal turmoil within the physician group. And then my next practice was working for a community health center that was run by Interior Health. And again, it had its advantages in that you didn't really have to work for much of the administrative and behind the scenes work, but there was a real lack of control in that situation. And so then I went and did my own practice. So I worked in the clinic and operated my own clinic and worked as a solo physician for probably about 7 years. And I really enjoyed that. I loved running the clinic, and I loved having my own patient panel and my own MOA, but it was quite lonely. And the access to allied healthcare providers was basically nothing. And so I probably would have continued to work in that environment if STEPS hadn't come into fruition. But then when STEPS was developed and I saw what a great system it was, I thought, okay, I think this is the way to go. It looked like, you know, great team-based care. It looked like a great model where there was transparency in the funding process. And it has, I would say, far exceeded my expectations, which is quite unusual within medical practice. Yeah, and it's mostly because I think it's a good model. It's very transparent. The people that are running the clinic don't have any ulterior motives. There's no kind of profit that they're concerned about. And so it's a good model. And I think the people that have signed on to the model have all similar ideals and values and goals. And so it's been very very nice that way. And working with the allied healthcare providers has just been amazing. You know, the social workers that we have and the clinical counselor, and yeah, the services are just fantastic. And I can't imagine going back to, you know, solo practitioner model.
Thanks. Chris, anything to add?
I did my residency in rural Manitoba, and it was a wonderful, wonderful experience in a community that really supported their care providers. And there was a community clinic that the community donated to and provided equipment for, held fundraisers for, et cetera, et cetera. And that was what I just kind of got used to. And that's what I sort of kind of expected, to be honest. Then I moved out here. I'm from here. So, you know, I finished residency. My wife and I moved out here, and there was nothing like that here when I first moved here. And so I locumed for a couple of years. I think I locumed at over 20 different clinics, trying them all on for size, trying to find something that resembled what I was looking for, and I couldn't find anything. And then I heard about this idea that was Shoreline, and it was exactly what I was looking for all along. And it's a supportive community healthcare center, really, with like-minded people that want to, you know, address higher level issues like you know, fixing attachment gaps in the community, and helping vulnerable populations, that kind of thing. And so I suppose that's kind of what I expected. And I think that's what a lot of residents and new grads expect now, right? Like that's the level of support that they want. And I was no different. I'm just a little bit ahead of them. So, yeah. So it was this or nothing for me, to be honest. We almost left Victoria. We almost moved because I couldn't find a clinic that, or an organization that met this description. So.
Thanks, Chris. Okay, Chris Naylor, your next question.
I think I'll do just one more maybe. I'm wondering if either of you have any support for physicians with more focused practices. So the examples from my own clinic, we have someone who works primarily with youth, which is without any extra funding. So I'm wondering if there's any examples of that. I think I saw that you had someone who maybe did a bit of work with youth at Shoreline. It may not be relevant, but any comments there?
Yeah, so we have, we have a doctor who does palliative care with a regular family practice. We have somebody who does a lot of youth and sort of transgender care. We have a maternity care provider. We had two. Now we're down to one maternity care providers. So I suppose, yeah, there are a few physicians with some focused practice, but not, like they still all have general practices. And I think that's a theme at Shoreline. Like everyone has a general practice, you know, everyone shoulders that load, and they have a special interest while maintaining a family practice. And they still pay the same sort of overhead. They still access the same supports. You know, they're still part of the same team. You know, we've set up internal referral processes for them, like, so, you know, referral forms, internal referral forms. We have MOAs who better understand those types of patients and their issues. And so we have like phone calls, say for the maternity practices, going to like one MOA or one team of MOAs that understand how the practice works. And that has really helped. So yeah, does that answer your question?
So I would say that we at STEPS are very similar to Shoreline. So most of the physicians have their regular longitudinal practice, and then there's a women's health clinic where there's internal referrals, but there's also referrals from outside of the clinic, most commonly for things like IUD insertions. And then we have a physician who's a hospitalist who solely does gender care clinic through STEPS. And Christine, I believe the gender care clinic has some special funding, does it not?
Yeah, so we top up her, so she has about, she actually has a general practice of about 60 people. And then she also does transgender and gender affirming care. And we top up that wage to a sessional rate because the care that she is providing for those people is, it's not feasible on the fee-for-service model. That's pretty much what it comes down to, yeah. And then we also have a physician who does outreach and does Indigenous care. And there's some funding, again, grant funding specific to that for travel, but the majority of everybody else does 70-30 split. But we do occasionally do work outside of that. Like we've had Indigenous communities ask if we can do women's health, bring women's health to their communities. And we've had like 2 physicians go out to that community, and that community will pay for, you know, the top up of that time to a sessional rate, because the fee for service structure just doesn't provide, it's not feasible unless we do it that way. We also have partnerships and agreements with different organizations that support different work depending on the population, but those are our main ones, and Dr. Smillie is exactly right. Everybody has a longitudinal general family practice, and then there's other kind of sub areas of interest that people have taken on, but primarily it's that 70-30 fee for service split. And then occasionally we're able to get grant funding if the care is not feasible for a certain population. You know, we look at making it feasible.
So. Hi, Christine. I was just wondering if I could ask a question on that in follow up. So when you say that, like, say a practice isn't financially, feasible, caring for a certain population of people, and so you guys provide top up wages, where does that money come from? Does that money come from grants? Does it come from community donations?
Grants.
Grants. And are there grants out there that are specifically for this?
Yeah, so we've been very lucky, especially with like community foundations who are interested in supporting specific populations, and that's really what we've been lucky and grateful for getting. But yes, there are specific types of grants that we've been successful in getting for specific work.
Great. It's great that you guys are learning from each other as well. That's always the bonus, yeah. And so I have a question about like a comment that you made, Chris, was around the overhead, that it was difficult to find some common grounds. And I hear like steps you provide like the 70-30% split, and then Shoreline 28-35%, depending on how how people work, like part-time or full-time. So can you elaborate a little bit of like why was it difficult to establish and how that is going?
No problem. So physicians don't like to pay overhead, fair enough. And when they do pay overhead, they want to pay what they feel is a reasonable amount, and they don't want to feel that they're paying too much. So there's different ways of paying overhead. There's fixed amounts where you pay a flat sort of monthly fee. There's percentage overhead models where you pay a proportion. And in general, part-time physicians certainly prefer to pay a percentage because then they don't have to pay when they're not working, and they don't have fixed costs to meet to keep up with, right? Full-time physicians in general prefer a fixed overhead model, so that they know they're not going to be charged excessive amounts of overhead that they would often be charged if they were paying a percentage model. And certainly when we started off, we had a flat overhead rate. And what we found was that our full-time physicians were paying way more than our part-time physicians. And ultimately, when you annualize that, like the absolute dollars that they were paying, it was far more than what they would have to pay in a solo practice or in a small sort of private practice in a fixed overhead model system. and we were actually looking at having a number of our full-time physicians, including myself, leave because that is not a sustainable financial model for an individual physician over a career. When you're talking $20,000 or $30,000, more than what you would expect to pay in a fixed overhead model, when you're paying a percentage, then you just can't sustain that. So the way our model works is it's a graduated overhead split that is recalculated every remittance, and as you cross certain thresholds, the overhead that is applied to the total goes down. So if I think it's $8,000 or less within a remittance, your gross billings received is $8,000 or less, then you pay 35%. Between $8,000 and $10,000 billings received, you pay 33%. On if your billings received is 10 to 12,000, you pay 30%, and if you bill anything in excess of $12,000, you pay 28%. And that flexibility allows for part-timers to not pay, a flat rate essentially, but it also means that when you annualize the overhead for our full-time physicians, it works out to be equivalent to what they would be paying in a fixed overhead system anyways, so they don't feel hard done by. So you can work harder to bring your overhead down, and that has actually resulted in more patients being seen as well. It's a bit of a carrot.
That's great. And Christine, you mentioned in the beginning of when you started with another funding model.
Yeah, we started with it was a base rate of pay. So it was a funding model that we paid the doctors a set amount per day. And we just learned that utilizing the fee-for-service model, it just wasn't financially viable. We did a lot of learning, and I think here part of the reason we went with a 70-30 model is because we didn't want to pull locums away from other family doctors and community. And our board and our physicians and our team is really conscious of not destabilizing our community and our region. And the market value is kind of that 70-30 is what the going rate is for having a locum come to other places, as well as attracting locums to STEPS. But we really wanted to make sure that physicians who were providing longitudinal family practice could access locums, and we weren't taking locums away from people because our funding model disadvantaged them in this environment. So we're pretty conscious and pretty careful about the decisions that we make around physician compensation. In the Thompson region, we have an unattachment rate of about 39%, and the provincial average is about 20%. And so we have huge unattachment challenges and capacity challenges and demand. And so we just need all of our physicians, including those at STEPS, including those in community doing solo practice or group practice, to be healthy and well. And that's very important to our board of directors and our team.
Can I ask a question? Sorry. Do you guys have anybody on the new to practice contract?
We don't, but we have two people who are looking at it, very seriously looking at it. And we have identified a number of great things for them, but challenges for having different compensation models within our organization. So we will be looking to work through those. We are also looking at, we did an expression of interest, STEPS did, through the BC Association of Community Health Centre, to create a community health center urgent primary care center, and we were approved the ability to go onto the proposal stage. And so we are looking at a top-up model that would not destabilize the region. But yeah, that physician compensation, how do we make sure that everybody is healthy and well and thriving to provide longitudinal family medicine? We're endeavoring to figure that out here for sure. It's definitely a huge provincial challenge, and I think that we can get there, but it definitely is hard.
We've considered the CHC model as well, or the CHC hybrid model with UPCCs. We've considered it, but we've heard some feedback from medical directors of other CHCs around the province, and that autonomy is a bit of a challenge. And that is certainly something that our physicians would not go for.
Yeah, we have been told that we are able to talk about policy with the BC Association of Community Health Centres to figure out what that would look like for community health centres to do this well. But I agree, the proof will be in the pudding. We'll see what the fine print looks like when it arrives.
One key piece for us is that in order to be a CHC, you cannot have physicians on your board, and that is one of the things that has made Shoreline so successful. And so, you know, it's a tough decision for us to make.
Yeah.
Yeah, that's a great segue into one of my questions. I think both of you spoke a bit about it. It's about the autonomy and flexibility and freedom of physicians. Because a lot of physicians, you know, in our community, they all have their own practice. And yeah, can you speak a little bit to that? How, you know, Tracey and Chris, you've moved, you know, from your own private practice to another area. Chris, you've locums, you saw other models. So can you talk about that?
I'm happy to speak about that. So yeah, anytime you join a group practice, even if you just go into a practice with one other doctor, you have to find common ways of doing things, and you have to give up some autonomy when you work with even one other doctor, and so you just have to collaborate and communicate and act transparently. And we do our best to allow our physicians to have autonomous practices, but there are certain things that we all have to sort of agree on and do the same. And so, for example, how we train our MOAs the same way. We provide them with the same sort of skill set, and they use the EMR the same way. And so we need our physicians to interact with our MOAs the same way. At first, when we got together, we had 25 physicians sending messages to the staff saying, book the patient in 2 weeks. Well, do you want that to be an in-person or telehealth, or how long, 15 minutes, 30 minutes, like all these questions that MOAs need to know. And because, you know, we're a large organization, we don't have that one-to-one MOA to physician relationship. Our MOAs don't know us intimately like a solo practice, like they would in a solo practice. And so we've had to develop like templates and sort of standardized ways of physicians interacting with MOAs or giving orders essentially, so that it's crystal clear, and then that allows our MOAs to function more efficiently. We've also had to establish standards, as I mentioned, with respect to documentation, and that was painful and challenging. There's a lot of pushback on that. So yeah, those are a couple of the pain points, and simply asking physicians to communicate it with MOAs in a very specific way using sort of templates created a lot of controversy, and it took us months and months and months of engagement just to get everyone to use the same templates. So physicians we like to be our own bosses, right? And we like to do things our own way. And so learning to work together is a part of the process, I guess. And that takes a long time.
Thanks. And Tracey, from your end, or Christine?
I was just going to say compromise and communication, hands down, the most important two factors to making this work across the board. It always comes down to that. I was really interested to hear what you were talking about, Chris, in terms of like suggesting the templates be used for communication. We haven't done that, and I'd be interested to see how it would work for us. The way that we've kind of been functioning around that is that we work in teams. And so like I belong to team 2, and I have a certain number and certain MOAs that work within that team 2. So it's a little bit easier to communicate what you want within that sort of smaller team. But I'm sure if you talk to our MOAs that work for STEPS, they would let you know that one of the challenges they face for sure is about not knowing what physicians want or how physicians are communicating, and it being so different. They can't read our minds. So I'm fascinated to hear that you worked so hard to use those templates, and I personally think that's a great idea, but I'm not sure that my colleagues would. And I agree. It's like, yeah, physicians like to be their own bosses for sure. But again, yeah, all about compromise and communication.
I think the important point is physicians still have clinical autonomy, but operational, decisions and workflows that require compromise and communication. Yeah.
Thanks. Christine, you wanted to say something about it? Yeah.
Yeah, probably two or 3 years ago, Tracey brought up the word of fair, like and figuring out what was fair for the society and fair for the physicians and fair for the team, and thinking about that fairness and what that means to everybody. And I think that always comes back to me is when I'm thinking about compromising communication and working through challenges or perceived rubs and money things and things like that. What is fair, and that word and figuring out what is fair for everybody has been, I think that has been a key to our success. And I very much reflect on that quite often.
Great. Well, we have 2 minutes left. I think we can squeeze in like one little tiny question. If there is anything burning still, Chris or Brigitte, any burning questions? No? Okay, then I would like to thank you very much, Christine, Tracey, Chris, and Karen, for taking the time. And it's too bad that not more people could join us live, but I know this video will definitely be watched by our physicians because many asked for it. And I know we also received some questions from other communities, if we could please share this with them. So we will make it available. Again, thanks so much. And I'm pretty sure our paths will cross again. And if there's anything we can ever repay you, if we come up with something in Powell River, then we would love to return the favor. Okay, thanks. Wishing everybody a lovely evening.
Have a great night. Thank you
so much.
Bye.